Dear Chairman, dear colleagues, my name is Luca Hergár and I would like to present you my 12 months progress, my PhD topic, Translational Keypoints between Radiology, Physical Examination and Hand Surgery. I'm a resident doctor at the Department of Orthopedics at Semmelweis University. My vision is adequate diagnosis at the first doctor-patient interaction, and my mission is to evaluate the accuracy of diagnostic methods in hand surgery. I am currently working on 3 topics. The first one is about the accuracy of magnetic resonance imaging for lesions around the wrist. The second one is about the correlation of two-point discrimination and electroneurography. And the third one is about the clinical applicability of two-point discrimination. The title of our first paper is investigating the diagnostic accuracy of magnetic resonance imaging for lesions around the wrist. So I'm sorry, I think this is not the up-to-date presentation. I'm very sorry for that, but I will update it in the presentation. So the first topic is about the wrist ligamentous and cartilaginous lesions, and today we are representing a lot of different specialties, neurologists, gynecology, and orthopedic surgeons. But I think what we have in common is that we want our patients to have the best care, the best possible care, and this starts with the correct diagnosis. So this is why I find this topic very important, and this is why we are investigating the accuracy of magnetic resonance imaging. Wrist soft tissue injuries are quite common pathologies. And for now, the gold standard diagnostic tool is wrist arthroscopy. But this is an invasive method with a lot of possible therapeutic options. But without a preoperative diagnosis, it's hard to plan the surgery, both for surgeons and for patients as well. So before the arthroscopy, there's the possibility of doing a wrist MRI imaging. But the accuracy of this diagnostic method is spread on a large scale, from 60 to 98%. And this is why the aim of our study was to determine the diagnostic accuracy of wrist MRI, and also to find out that what are the factors that are influencing this diagnostic accuracy. We included papers where they examined patients with suspected cartilaginous or ligamentous lesions of the wrist. The index test was wrist MRI, and we compared it to the gold standard arthroscopy. Our outcomes were the diagnostic accuracy, the sensitivity, and specificity of this method. After the systematic search, we found 38 eligible full text. We completed the data extraction. And here you can see the overall sensitivity and specificity of the MRI, what we found. We found the sensitivity to be 75% and the specificity to be 85%. But we were interested that if we analyze different subgroups, that what are the exact, how can we improve these values? Here you can see the sensitivity and specificity based on the technical conditions of wrist MRI. We found that with the increased field strength, the specificity increases in a very important way from 65 to 95%. With the application of wrist coils, the sensitivity also improved in an important way, as well as for the application of 3D sequences. We found that the fat saturation increased the specificity in a more important way. Not only the technical conditions, but also the anatomical location is an important factor when we are examining the accuracy of wrist MRI. We found that the best results were achieved when we examined the central or the peripheral tier of the triangular fibrocartilage complex. And for other lesions, such as the scapholunate ligament lesion, we found that the best results were achieved when we applied 3 Tesla MRI imaging. For the lunotriquetral ligament lesions, the sensitivity was quite low, but the specificity was high. So this is also an important thing to keep in mind when we are ordering these examinations. Currently, with this topic, we are just a few days from submitting the manuscript. We just have some minor changes to be done. The strength of our study is that we included a large number of studies, and the study unit was the ligamentous lesion. So if a patient had both triangular fibrocartilage complex lesion and lunotricutal ligament lesion, then these both were calculated separately. We took into account variable factors such as the field strength of the MRI machine and the application of special sequences and risk scores. We are aware that our study is limited by the heterogeneity of the included studies and the different lesion classifications what we found in different research papers. All in all, we can say that MRI is a reliable tool in the preoperative diagnosis for wrist ligamentous lesions as long as the right technical conditions are met. We advise the implication of our study in practice to encourage the discussion between hand surgeons and radiologists to achieve a better and more accurate preoperative diagnosis. We encourage clinicians to set up clinical guidelines for the wrist MRI and also the application of greater field strength, if it's possible, during MRI imaging. For researchers, we advise the precise documentation and also the comparison of different MRI settings, such as slice thickness, the application of risk scores, and special sequences. My second project is about the correlation between two-point discrimination and electroneurography in carpal tunnel syndrome. In carpal tunnel syndrome, the median nerve is under compression, and this causes motor and sensory loss of function. To diagnose this illness, the gold standard diagnostic tool is electroneurography and electromyography. This is also an invasive and painful diagnostic method. And this is why we wanted to examine whether the two-point discrimination measurement, what you can see on the picture in the corner, can be useful in the diagnosis of this disease. In this study, we included patients with carpal tunnel syndrome. We measured the two-point discrimination values and compared it to the electroneurography values. The outcome was the degree of severity. And we found that there's a significant correlation between the distal sensory latency and the severity of electroneurography. And these correlated with the category of two-point discrimination values and also the highest value of two-point discrimination. But this correlation was quite weak, so it seems that in the clinical practice we can't say that with higher two-point discrimination values the sensory function will be decreased as well. And this leads us to our third project. This is about the investigation of the effects of different conditions on two-point discrimination values. As we found in our second project, the correlation is not always evident with the sensory loss of function and an increased two-point discrimination values. And we were interested that what is the reason behind this difference? Can there be different conditions in the general population that affect the two-point discrimination values, such as the age of the patients, the gender, pregnancy, or cortical function? And this is what we would like to examine in this meta-analysis, different conditions in the general population that might have an effect on the two-point discrimination values. We have completed the systematic search in December, and as we focus more on the first and the second project, now we are in the full text selection phase. And once the first article is submitted, we hope to move on soon with the third project as well. So I would like to thank you very much for your attention, and I would like to close my presentation with a quote from Antoine de Saint-Exupéry: "A goal without a plan is just a wish." Thank you very much.
Thank you for your presentation. I just want to ask you, for the second project, how well are the cutoff values defined for the 2-point discrimination? Because in the third one you said that there are so many variables that could affect it.
Yes, that's right. What we used in the second project is the guideline of the American Association for Surgery of the Hand. And there are 3 categories. So for normal values, they consider when the 2-point discrimination value is under 6 millimeters, for moderate severity between 6 and 10 millimeters, and above 10 millimeters, it's considered as a severe damage in the sensory function. And in the third project, we would like to evaluate whether this is still a correct classification, or maybe we need to rethink this classification.
So you consider it, the diagnosis, to be correct after 10 millimeters, if the 2-point discrimination is more than 10 millimeters?
If it's above 10 millimeters, then we consider that there is a sensory loss of function. And the question is that what causes this sensory loss of function? Can it be in the normal range? For example, for elder people, it's proven in several papers that the 2-point discrimination value is increased. So our question is more that, is it a normal variation that for elderly people the sensory function is a bit lower than for younger people, or we should consider this as a sign of an illness and we should look for carpal tunnel syndrome or any other nerve compression?
I would like to ask a question actually, Luca, that of course always when we will have new results, then other researchers can attack or question our results, and of course in this case we were just discussing that nowadays arthroscopy is much easier to perform. First of all, it's the duty of the orthopedic, and the patient doesn't need to wait as much as for an MRI, for example, for half a year. And actually when an arthroscopy can take, even if it's not a diagnostic but a therapeutic one, it takes 1 hour, but an MRI takes half an hour, and also they will have to perform the arthroscopy as well. So what do you think, how can you convince actually people that they should use it, or actually in which situations they can use it for sure?
Yes, it's an interesting question, because in some of the studies, what we included in our meta-analyses, patients had MRI before the arthroscopy, and in some cases, when the MRI was negative, they considered conservative treatment for the patient. So of course, a surgery, even if it's an arthroscopy, it presents risk for the patients, and not everybody is happy to go on with the arthroscopic procedure if it can be avoided. And in the case of a negative MRI imaging, if we can advise conservative treatment, there might be patients who think that it's worse having an MRI imaging, even if it means that they have to wait a bit if their symptoms are not that severe or not that painful. And with that, they can avoid a surgical procedure. Of course, we can say that for now, the gold standard procedure is arthroscopy. So until we have this, we don't have the final and most definite diagnosis. But we can still wait a bit and see if the symptoms improve, because this is also a possibility.